Hi everyone, I am Fumi Urano from Washington University School of Medicine. I am a professor of medicine and attending physician at the Center for Advanced Medicine at Washington University Medical Center. So thank you for inviting me to this talk. Dr. Maffei is here, I can see. So today I'm going to talk about Wolfram syndrome. So these are my disclosures. And I'd like to thank all of my collaborators and the people in my research group. This is a collaboration walk. So today I'm going to talk about Wolfram syndrome, and I'm going to focus my time on our therapeutic development, therapeutic options for Wolfram syndrome. So Wolfram syndrome is an ultra-rare genetic disorder characterized by juvenile onset diabetes, and most patients are insulin dependent, and some patients take GLP-1 receptor agonists such as liraglutide. Patients also develop optic nerve atrophy, and many patients become legally blind or blind. And deafness is common, and neurodegeneration is a major issue. And the neurodegeneration is characterized by cerebellar ataxia and also brainstem atrophy. And there are two causative genes, WFS1 and CISD2. Most patients carry pathogenic variants, autosomal recessive pathogenic variants in the WFS1 gene. And as I just mentioned, most patients carry pathogenic variants or mutations in the WFS1 gene, and Wolfram is, generally speaking, autosomal recessive disorder. So most patients carry two pathogenic variants, two bad copies of the WFS1 gene. We found some patients carry just one autosomal dominant pathogenic variant. It's really rare. And there is another causative gene called CISD2, also very rare. Prevalence is probably 1 in 200,000 to 500,000. So WFS1, Wolfram syndrome, is a spectrum of disorder. So from mild to severe. Typical patients with Wolfram syndrome have two autosomal recessive pathogenic variants, and they develop diabetes mellitus, diabetes insipidus, optic nerve atrophy, hearing loss, and neurodegeneration. We also identified distinct groups of patients who only develop diabetes only, hearing loss only, cataract only, or optic nerve atrophy and hearing loss only. And optic nerve atrophy in this case is relatively mild as compared to patients with typical Wolfram. These patients carry only one dominant pathogenic variant in the WFS1 gene. Dr. Hattersley's group and my group identified a different group of patients who carry WF variant. These patients also have only one bad copy of WFS1 gene, and they develop neonatal diabetes, congenital cataracts, sensory neural deafness, and hypotonia. So Wolfram is a spectrum of disorder. So this variant, WFS1 W314R variant, is associated with adult onset diabetes. So these patients carry only one pathogenic variant in the WFS1 gene, and they only develop diabetes. These are the dominant variants that can cause neonatal diabetes, congenital sensory neural deafness, and congenital cataracts. Interestingly, our group and also another group identified WFS1 R558C variant. This is our collaboration with Do Yesharim and the NIH in the United States. And this variant is very common in Ashkenazi Jewish population. The carrier frequency is 3%. So 3 in 100 Ashkenazi Jewish people carry this variant. And if you are homozygous of this variant, that means if you have 2 copies of R558C variant, you develop mild form of Wolfram syndrome. So you may develop optic nerve atrophy only, or diabetes only, or you may develop both, but mild. So this is a variant we are very interested in right now to develop new treatments. So as you can see from these slides, to diagnose patients with Wolfram syndrome or Wolfram syndrome related conditions, it's very important to do genetic testing. So genetic testing include sequencing of WFS1 gene, also sequencing of all the genes associated with monogenic diabetes or syndromic diabetes. So this is a molecular pathway regulating WFS1 gene expression. So WFS1 is a causative gene for Wolfram syndrome, and we identified WFS1 is a component of the endoplasmic reticulum stress response, also called unfolded protein response. So endoplasmic reticulum stress, also called ER stress, is a cell stress induced by misfolding of newly synthesized protein. So this pathway was revealed by my former student, Sonia Fonseca. Now she is an investigator at Novartis. So WFS1 encodes, WFS1 gene is on chromosome 4, P arm, so smaller arm, and WFS1 gene encodes transmembrane protein localized to the endoplasmic reticulum. So this is a very molecular, but WFS1 is localized to the endoplasmic reticulum, and also small portion of WFS1 is also localized to the granules, identified by Dr. Barrett and Tanizawa. And also WFS1 is mainly localized to the endoplasmic reticulum. And it has at least 2 roles. It's important for endoplasmic reticulum homeostasis, and also it's important for regulating endoplasmic reticulum stress response too. So if there is no WFS1, there is high level of endoplasmic reticulum stress, and also dysregulation in endoplasmic reticulum calcium homeostasis. So these are the functions of endoplasmic reticulum. Endoplasmic reticulum is an important cellular compartment executing multiple functions, including redox regulation, protein folding of newly synthesized protein, autophagy, protein degradation, and regulation of life or death, and calcium storage. And loss of function of WFS1 leads to dysregulated endoplasmic reticulum calcium homeostasis. So this is my research group, who contributed the work that I'm going to show today. So this is a very simplified pathogenesis of Wolfram syndrome. So root cause of the disease is the mutation in the WFS1 gene. And the WFS1 gene mutation can lead to the loss of function of WFS1 protein, which leads to endoplasmic reticulum calcium leakage to the cytosol. And because many enzymes in the endoplasmic reticulum depend on calcium, that can lead to endoplasmic reticulum stress, also imbalance between endoplasmic reticulum calcium levels and the cytoplasmic calcium levels can also cause some cellular dysfunction, and which eventually leads to clinical manifestations, including diabetes, optic nerve atrophy, and neurodegeneration. So there are 3 points that we can target to develop new treatments for Wolfram. So I will go through one by one. our first approach was to target endoplasmic reticulum calcium leakage using small molecule, i.e. medication. So we looked for drugs that can manipulate or that can restore endoplasmic reticulum calcium homeostasis. So we looked for FDA-approved drugs, in your case EMA, you are in Europe. And we also looked for new drugs. So we try to identify FDA-approved drugs that can prevent endoplasmic reticulum calcium depletion-mediated cell death, which is a molecular mechanism of Wolfram. And so screening is like a fishing. This is my son who got some fish. And so we identified 8 known molecules, medications that can restore endoplasmic reticulum homeostasis. And we became very interested in Dantrolene sodium. So Dantrolene sodium is an FDA-approved drug for the treatment of malignant hyperthermia. Malignant hyperthermia, many physicians know, malignant hyperthermia means some people are very sensitive to anesthesia, and during operation, after the anesthesia, some people develop high fever and muscle stiffness. So Dantrolene sodium is utilized for the treatment of such condition. How does Dantrolene sodium work? Dantrolene sodium targets ryanodine receptor localized to the endoplasmic reticulum. So there are 3 channels controlling endoplasmic reticulum calcium homeostasis. These are IP3 receptor, SARCA pump, and ryanodine receptor. IP3 receptor is important for releasing calcium. SARCA is important for importing calcium into the endoplasmic reticulum. Ryanodine receptor is important for releasing calcium from the endoplasmic reticulum to the cytosol. Dantrolene inhibits ryanodine receptor so that ER calcium levels are high. So this was identified by Simin Liu, my former graduate student. Now she is she's assistant director at Wuxi Biologics. That's one of the major biotech company in Shanghai, China. So Dantrolene sodium prevents cell death and calpain activation in WFS1 deficient beta cells and neuronal cells. So we created cell model of WFS1. We basically knocked down WFS1 gene in beta cells and neuronal cells. And then we looked at caspase levels. Caspase levels reflect cell death levels. So when caspase 3 activity is high, cells are dying. And the spectrin is a marker for cytoplasmic calcium levels. So when ER calcium leaks out to the cytosol, spectrin is cleaved out by an enzyme called calpain. So when cleaved spectrin levels are high, that means there is dysregulation in calcium homeostasis. So as you can see, WFS1 depletion increases cell death, and Dantrolene sodium treatment could reduce cell death rate. As you can see, cleaved spectrin levels also go up by WFS1 gene depletion, and this can be also restored by Dantrolene sodium treatment. So this was really encouraging. So we created iPSC cells from patients with Wolfram syndrome. So iPSC stands for induced pluripotent stem cells. So this is a very good model for any genetic disorders or any human disorders. So iPSCs can be differentiated into any types of cells, and we can use these cells for drug screening or regeneration of damaged tissues. So using Wolfram syndrome patient iPSC cells, we created brain-like cells, and these brain-like cells are susceptible to cell death. So as you can see, the darker band means cells are dying. And by treating these cells with Dantrolene sodium, we could reduce cell death rate. So the intensity of the band decreases by the treatment of dantrolene sodium. We also did some animal experiments, and these were all positive. So based on these results, we could get FDA approval for the treatment of FDA approval, orphan drug designation of dantrolene sodium for the treatment of Wolfram syndrome. We could also get the approval from European Medicinal Agency. And so to start a clinical trial in the United States, we got IND from the FDA. This is called the Investigational New Drug Status. And then early in 2018, we enrolled 21 patients for the clinical trial of dantrolene sodium in patients with Wolfram syndrome. So this is how we did clinical trial. So we screened patients first. So at the screening visit, we looked at their diabetes, we looked at their visual acuity, how well they can see, and we also looked at their neurological functions using our disease rating scale developed by Professor Hershey at Washington University, my long-term collaborator and friend. So then we treated patients with Wolfram syndrome with dantrolene sodium. And we gradually increased the dose, and sometimes we decreased the dose based on their side effects. Then we monitored their diabetes, visual acuity, and the neurological functions after 6 months. So this is what we did, and these are this is a demographic and clinical characteristics of patients who participated in the trial. So we included both pediatric and adult patients. And so then I'm going to show the results. So we focused on 3 endpoints. So first endpoint was the endocrinology related endpoints. So we tried to determine the effect of dantrolene sodium on remaining beta cell functions using mixed meal tolerance test and monitoring baseline C-peptide levels, blood glucose levels, proinsulin C-peptide ratios, hemoglobin A1C levels, and urine glucose levels. So the mixed meal stimulation C-peptide mildly increased after 6 months dantrolene treatment. So mixed meal tolerance test is a good way to look at remaining pancreatic beta cell functions. So patients were fasted, then we gave them a boost, which contains high carbohydrate and also still some fat and protein. And then after 30 minutes, we drew blood and we looked at their C-peptide levels, which is insulin produced in their own pancreas. And after 6 months treatment, we saw mild increase in their C-peptide levels after the boost, 0.52 to 0.71. And this was analyzed by Damien Eblu, who is an MD PhD student in my lab, and also the Dr. Stephen Stone. Now he's also Professor Stephen Stone. He also analyzed the data more carefully, then realized there are 2 groups of patients who responded to dantrolene sodium and patients who did not respond to dantrolene sodium. So some patients responded to dantrolene sodium and their C-peptide levels went up after 6 months. 0 and 6 means 0 means before the treatment and 6 means after 6 months. So some patients responded to dantrolene sodium. And this is the overall result of the mixed meal stimulated C-peptide levels in our participants. We also looked at their vision. So to determine the efficacy of dantrolene sodium on visual acuity, we used a logMAR scale. So in the US, we use the Snellen chart to assess our visual acuity, and 20/20 means basically the perfect vision. And if you see really, really well, it could be 20/10. And if you don't see well, the vision is called 20/200. So that when this number is high, that means you don't see very well. And we created a logarithm of the Snellen chart-based scores. So which means if you see very well, the logMAR number is low, and if you don't see well, your logMAR number is high. So that's how this works. So here is the visual acuity after the 6 months treatment of dantrolene sodium. So there is no difference. So fortunately, patients' visual acuity was stable, and according to Professor Hershey's study, actually in 6 months most patients' visual acuity don't change. So this means dantrolene sodium may not affect visual acuity. So we need to look at the visual acuity longer period of time. So this is again visual acuity. Then we also Professor Stone looked at their visual acuity in responders and non-responders based on their C-peptide levels, diabetes. And interestingly, in responders we see some trend. Responders, maybe their visual acuity gets a little better. But I don't want to do any overstatement. So basically, in 6 months, it's very difficult to see the difference in visual acuity because visual acuity does not really change in 6 months. We also looked at neurological functions using Wolfram syndrome unified rating scale. Basically, every time we find some problem, we give them a number. And if we don't find any problem, we don't give them any score. That means high number means more advanced stage of the disease. So lower is better. So here it is again. It seems like in responders, their disease rating scale number decreased or stable. So that's kind of interesting because the number of participants is so small, it's difficult to make any conclusion, but we found this interesting. So here is the summary of a clinical trial. So we could identify safe dose. We could identify the safe dose, which is in pediatric population in between 0.5 milligram per kilogram per day to 2 milligram per kilogram per day. In adults, 50 milligram per day to 100 milligram per day. And dantrolene sodium may improve beta cell function, may improve disease rating scale. And patients with better baseline beta cell function tend to have the most benefit from dantrolene sodium. And this is clearly an uncontrolled study, so placebo effect cannot be ruled out. And also, we found some common side effects. These are fatigue and diarrhea. Now I'd like to switch a topic, and I'd like to talk about gene therapy for Wolfram syndrome. So for gene therapy, we think there are 3 options. Transfer normal WFS1 gene, correct mutant WFS1 gene, and our third option is to deliver regenerative gene. So we are testing 3 different options. The first option is to transfer normal WFS1 gene using adeno-associated virus. So now adeno-associated virus is becoming famous because it is also utilized for developing vaccines for COVID, especially in England. Oxford is using this system. But AAV is currently used for the treatment of multiple genetic disorders because AAV is safe, and also AAV can transfer any genes into target tissues, including brain cells and retinal or eye cells. So we created AAV2WF1, AAV2.7M8WFS1 for eyes, AAV9WFS1 for brain, and we are testing intravitreous, stereotaxic tail vein, and intraperitoneal injections of these viruses. So we are utilizing multiple mouse and rat models of Wolfram, and so some of them were created in my own lab, and some of them were actually two of them were created in Europe, in Estonia, and one was created in Japan at University of Yamaguchi. So I'm going to show some results later on, but I'd like to summarize. We are also testing the correction of mutant WFS1 gene by gene editing. So we made significant progress in this project. So I'd like to show you the summary of our discovery. So as I mentioned earlier in my talk, we can differentiate Wolfram patients derived iPSC cells into different types of cells, including pancreatic beta cells, retinal ganglion cells, and brain cells. So we corrected gene mutation in Wolfram patients' derived iPSC cells using CRISPR-Cas9. We differentiated these cells into pancreatic beta cells. So WS13 unedit means original iPS cells, and CORR means corrected. So after the correction of mutation by CRISPR-Cas9, we differentiated them into pancreatic beta cells. Then we looked at their functions. So we basically stimulated these cells with high glucose, then looked at insulin secretion, insulin production and secretion. As you can see in the left side of this slide, by correcting mutation, these cells started producing more insulin. And we also transplanted these cells into diabetic animals, and we could cure diabetes. So which means this is a proof of concept. I'm not telling you that we can immediately use this technology for our patients, but this is very important because proof of concept. By correcting one of two mutations that each patient has, we could completely restore the function of pancreatic beta cells. So this is really encouraging. And so we are clearly doing more experiments. So number 3 for gene therapy is to deliver a regenerative gene using AAV or CRISPR-Cas9. So we are focusing on a molecule called MANF. MANF is a secreted molecule and 50 kilodalton. So what's MANF? MANF can be utilized for regenerative therapy. So MANF secretion, production and secretion is induced by ER stress. MANF confers protection against ER stress-mediated cell death, and MANF promotes cell proliferation in WFS1 deficient cells. So what's MANF? MANF is usually localized to the endoplasmic reticulum. When endoplasmic reticulum calcium is depleted, which is seen in patients with Wolfram, MANF can get out from the cells, then can come back to cells and activate survival and cell proliferation. So which is a very interesting molecule. So we are trying to deliver MANF using AAV into cell and animal models of Wolfram. So what we did was we created AAV9 MANF, and we injected AAV9 MANF into a mouse model of Wolfram. In this case, WFS1 gene, beta cell specific WFS1 gene knockout mice. So these animals spontaneously develop diabetes. And by injecting AAV9-FS1, we could increase the number of proliferating beta cells. So left side is, so red means these cells are proliferating, and we calculated the ratio. And so by injecting, so if you see right side of this slide, the number of proliferating cells increased by injecting AAV9 mouse. So this is encouraging. So we want to replicate this success in brain cells and eye cells. So we are currently focusing on eye cells. So because we want to improve their eyesight in patients with Wolfram syndrome. So we are using two preclinical models, patient iPSC-derived retinal organoids and rodent models. So we created multiple lines of patients with multiple iPSC lines of patients with Wolfram syndrome. These are the patients who have typical Wolfram syndrome. We also created iPSC cells of patients who have milder form of Wolfram syndrome. So we are focusing on patients with severe manifestations, and we are also looking at patients with milder manifestations. So then, we create eye cells, and so this is how we create retinal ganglion cells. So Dr. Yume Wan, he has been working on, retinal ganglion. He has been working on the mechanisms of optic nerve atrophy in patients with Wolfram syndrome. And so in patients with Wolfram syndrome, there is a degeneration of retinal ganglion cells. So retinal ganglion cells are important for transmitting light signal to the back of the brain. So retinal ganglion cells to optic nerve atrophy, optic nerves to back of the brain, then we create image in our brain. So, but in patients with Wolfram syndrome, retinal ganglion cells degenerate. So we are creating retinal ganglion cells using iPSC cells. So this is our protocol. So we created a very good protocol. It takes 84 days right now to make retinal organoids. So these retinal organoids express markers for retinal ganglion cells. So Brunsrid is one of them. And these organoids look like this. So cells inside are retinal ganglion cells. And interestingly, retinal ganglion cells express high levels of WFS1. So these are other pictures of Wolfram syndrome patients, iPSC derived retinal ganglion cells. So CORR means these are the cells in which mutations were collected by CRISPR-Cas9. So both patient-derived iPSCs and collected iPSCs can be differentiated into retinal organoids. And these are the retinal ganglion cells differentiated from Wolfram syndrome patients derived iPSCs and also collected iPSC lines. So if you look at inside, these are the retinal ganglion cells. Green cells are retinal ganglion cells, and they also express WFS1. So we are characterizing these retinal ganglion cells, and we are also transferring mouse WFS1 into these retinal ganglion cells to see if we can restore any functions. So this is ongoing. And we also have rodent models. So rodent models of Wolfram develop optic nerve atrophy. So VOS is a way to look at visual acuity in mice and rats. So we are looking at visual acuity in both mice and rats. So after 3 months, after 5 months, their visual acuity declined significantly. So we try to, and also the retinal ganglion cell thickness changes after 3 months in Wolfram syndrome mouse model, WFS1 knockout mice. So retinal ganglion cell thickness changes, much thinner in Wolfram syndrome mouse model. And this is another way to look at the retinal nerve fiber layer thinning in Wolfram syndrome mouse model. So these are our outcome measures. So we are injecting AAV MANF and AAV WFS1 in these mice to see if we can improve visual acuity or thickness of retinal ganglion cell layer and also rates of retinal ganglion cell death. So that's what we are looking at. And we don't have the result yet, but we have 3 cohorts. We injected MANF, and we injected WFS1, and we are injecting MANF again late December. So hopefully we can, I can show you some positive results in 2021. So this is how we do experiments, intravitreal injections. And we could successfully transfer MANF into retinal ganglion cells. So green signal comes from MANF, AAV MANF. So this is a lot of work, but we are making progress. Okay, so we are almost done. So this is a therapeutic development pipelines and timeline. This is a slide describing our therapeutic development. And so mutant WFS1 gene to mutant WFS1 protein to cell death. So we have 3 points to target for the treatment for developing treatment. So we are focusing our efforts on gene therapy, which is a very upstream of the disease-causing mechanism. But we are also targeting a relatively downstream, which is endoplasmic reticulum stress or dysregulated EM homeostasis. And many of these medications are already available for us. So these are called drug repurposing studies. And we have 6 candidates: Dantrolene sodium, liraglutide, GLP-1 receptor agonists, including liraglutide, and ibudilast, and MP101-201. We are also targeting in the middle. So to target upstream, the very upstream is gene therapy. Target downstream is pharmacological compensation of ER stress, but then we can also target in the middle. So we are trying to enhance the residual function of mutant WFS1 protein, and also this compound can mitigate endoplasmic reticulum stress. So the name of the compound is AMX0035, and this is a collaboration with a biotech company in Cambridge, Massachusetts called Amylyx. And we are making steady progress for this. So hopefully we can start a clinical trial next year, hopefully, or maybe 2022. 2021 is our goal. That's all, I think. Yes. So thank you for your attention. And so this is my very last slide. So it takes a village to achieve a cure for Wolfram syndrome. So we need to improve clinical care, and we need to raise awareness together with patient organizations, and we need to develop therapies. So this should be a group effort, and I appreciate my collaborators and patient organizations and everyone who supports me. Thank you.
Hi, it's Tim. Hi.
Hello.
Excellent talk. Really enjoyed it. What's the situation regarding biomarkers for the progression of the neurodegeneration? Anything on the horizon to shorten the time from which you can shorten clinical trials by an earlier biomarker that can indicate if a treatment is likely to help the neurodegeneration or not? Any progress on that?
Yes. Hello, can you hear me?
Yes, thank you.
Okay. Yes. So as you know, the Professor Percy has been looking at NFL, and that's one of the potential biomarkers. And also there is another biomarker. It's a oxidative stress biomarker called, I blanked out, I'm sorry. But we are also looking at several oxidative stress biomarkers, and one of them seems to be positive. So I'm sorry, I just blanked out the name of the molecule. And also we are also looking at inflammatory cytokine markers too. So we are looking at NFL and oxidative stress biomarker, and also inflammatory cytokines too. And it seems like NFL is one of the best ones, but we are still looking into those.
About Dantrolene effects on C-peptide, you have shown some data about this. My question is related to the fact that C-peptide and insulin in physiology are affected by calcium. So I wonder, did you have any insight of the fact that your effects on C-peptide are really, mediated by an amelioration of oxidative stress on the endoplasmic reticulum, or just a pharmacological effect cause you in some way work on the calcium pathway, which any kind of therapy on that affect the calcium pathway could ameliorate in some way C-peptide production or insulin secretion?
That is a great question. I think, this is what I think. I think this is probably related to endoplasmic reticulum stress reduction. The reason is the effect of dantrolene, but it's also still possible that cellular calcium homeostasis is restored by dantrolene sodium, which has positive effect on insulin secretion. So I think it's probably both. And the reason I'm telling you this is that we see a better effect of dantrolene sodium on C-peptide levels in patients who have higher baseline C-peptide levels. So suggesting that, maybe dantrolene sodium restore calcium homeostasis, which improves the insulin secretion. And so I think it's a combination of both, and it's hard to differentiate these two. So I think it's a combination of both: reduction of ER stress and restoration of calcium homeostasis, which is important for insulin secretion, because calcium is, as you know, the strongest activator for insulin secretion.
Thank you.